Call upon Dr. T. Balasubramaniam sir to take his place as the examiner. I call upon the next presenter, Dr. Prasoon Sebastian from Calicut Medical College, to come here and present his case.
Good afternoon, sir. Okay. I would like to present the case of Phula Devi, 63-year-old female patient from Ranchi, Jharkhand. She is a housewife, and history was given by herself and her son, and the history is reliable. She came with complaints of generalized edema of 1 month duration. I would like to start her history from her onset of illness in 2021. She was apparently normal by then, noticed abrupt onset of period edema in March 2021, which gradually increased in severity, extending to a upper extremity of body, resulting in abdominal distension and facial puffiness. Along with, she noticed frothing of urine, but no history of gross hematuria, no history of decrease in urine output. It was not associated with any significant dyspnea on exertion or breathing difficulty on lying down position, no history of yellowish discoloration of eyes or sleep abnormalities or bleeding manifestation. She also noticed early satiety and nausea during this period. There was no history of loss of appetite, recurrent fever, joint pains, oral ulcers, or skin lesions. No history of intake of any medications prior to onset of illness. No history of chronic low backache or chronic non-healing ulcers or history suggestive of peripheral neuropathy. For this complaint, she consulted in local hospital and she received some treatments but noticed no improvement in her illness. And she consulted multiple hospitals, and from one hospital she was told that she is having some protein leak in urine, and she was referred to nephrologist. So the nephrologist confirmed the same and was asked her to get a renal biopsy, and the procedure was done from there. And post-procedure, no complications were reported to her, and no communication regarding an abnormal blood pressure for this patient or renal impairment was communicated to the patient. She was started on some medications, and she had continued that medication for around 2 to 3 months, following which she noticed no improvement in her symptoms and noticed increased facial puffiness and development of acne over her face. In view of persistent symptoms, she came to Vellore by October 2021. She got admitted in hospital, and she was treated with some kind of IV medications and was IP for around 2 weeks in CMC Vellore. And during that period, she underwent a renal biopsy, a repeat renal biopsy, and she was told that she is having kidney disease causing protein leak and which require prolonged treatment. She was also told that she is having some elevated blood pressure and require treatment for that same. No communication regarding renal impairment was communicated to the patient, and she was started on a post-biopsy. No costly investigations were suggested to her. And she was started on a medication, which she recalled as Arpimune, which was taken twice daily, along with some other medications, including one antihypertensive agent. And patient noticed improvement in her edema and was having regular monthly follow-up for the next few months. At 3rd month, she came for a follow-up. She noticed her edema subsided significantly, and the doctor communicated that she is persistently having protein leak, even though it was decreased in intensity. At that time, she has no other GI symptoms and was relatively asymptomatic. She continued the treatment for the next 2 months, following which she stopped all her medications by herself. After 1 month of stopping medication, patient noticed the reappearance of edema on the bilateral lower limb, along with abdominal distension, along with some GI symptoms over a period of next 3 to 4 weeks. For these symptoms, she again consulted in CMC Vellore and got readmitted and received some IV medications, following which she noticed improvement in her symptoms and edema decreased, and she was restarted on the same medication which was given initially, that was the Arpimune. And since then, patient is having regular follow-up and he has good compliance to the medications. On follow-up visit, her blood pressure were well controlled, and she was communicated that her illness is improving, but was having persistent proteinuria. After 6 months of restarting this treatment, on follow-up visit, she was told that she is still having a high protein leak and need a costly injection, which patient told that which was costing around 35,000 per dose, requiring 2 doses, and the patient got that costly injection, 2 doses, at 2 weeks apart, and she has stopped the Arpimune following that injection. Patient had no significant symptoms at that time except for the mild persistent period edema. Since then, patient continues to have a regular follow-up and was taking the medication which was prescribed, and she was relatively asymptomatic except for mild persistent period edema, and she was doing all her routine activities. She didn't have any nausea, early satiety, or any GI symptoms. But on follow-up visits, she was told that she is having mild persistent proteinuria. And recently, around 6 months back, that is after 1 year of giving that costly injection, she was again asked to restart on her Arpimune, which she was taking till 10 days back. Now, present symptoms dated back to 1 month back, when she noticed increase in peel edema, followed by abdominal distension and facial puffiness, along with reappearance of cloudiness of urine. She had associated nausea, decreased appetite, early satiety, similar to her past episode. For this, no history of any drug default, no history of recent fever, dysuria, cough, rhinitis, or no history of intake of any alternative medications. For this symptom, she was again readmitted in hospital, received some medications, and her symptoms currently improving, and got discharged 3 days back. And personally, she's waiting for her next follow-up visit after 2 days. So coming to past history, no history of any diabetes, hypertension in the past prior to this onset of illness, no history of tuberculosis, bronchial asthma, or ischemic heart disease, no history of non-allergy to any substance, and no history of any recurrent UTI. Family history, she had 3 elders and 3 younger siblings, no history of any renal disease in her family, and she has 6 daughters and 1 son, and no non-renal disease for the children. Personal history, she takes predominant vegetarian diet, sleep and appetite normal, and no addictions. She belongs to a low socioeconomic class, and menstrual and marital and obstetric history, she has 7 children. The last childbirth was 28 years back, and she had no complication during her pregnancy period, attained menopause at the age of 50 years. And treatment history, she was not on any medications prior to onset of her illness. Coming to general examination. Patient is conscious. Okay, sir. Okay, sir. A 63-year-old female patient with no comorbidities presented 2 years back with a gradual insidious onset generalized edema, gradually increasing severity along with frothing of urine, for which it was not associated in systemic symptoms, took some medications but got no treatment, and underwent a renal biopsy, following which likely she received steroids with no response, and underwent a repeat biopsy from Vellore, following which she was started on probably cyclosporine and had attained some symptomatic response but with persistent proteinuria on evaluation. And she had a symptomatic relapse after 5 months of initiation of treatment following the drug default, and after 6 months of reinitiation of cyclosporine, patient was given 2 costly injections, probably rituximab, and she had relatively asymptomatic although persistent proteinuria for the next 1 year, and restarted on cyclosporine 6 months back, which she was continuing till 10 days back when she got admitted with a symptomatic relapse with abdominal distension, edema, and frothing of urine, for managed conservatively, and now symptomatically better. And urine analysis done, which showed albumin 4+.
So you'd like to give a diagnosis or a differential diagnosis?
So my syndromic diagnosis is anyway adult onset nephrotic syndrome, and coming to steroid resistant nephrotic syndrome, and probably CNA resistant too. And I would like to give etiology close differential diagnosis. The first differential diagnosis I would like to make is primary FSGS, and the close second differential diagnosis is primary membranous nephropathy, and the distant third differential diagnosis is MCD.
Why do you say primary FSGS as your first possibility in a 64-year-old lady?
Yes, sir.
How common is FSGS in 64-year-old?
So that's why it all is close differential diagnosis. FSGS is unlikely as the age goes. It is more common in the 3rd and 4th decade. Even less than 40 years, it is said more common. And after 40 years, the most common cause of nephrotic syndrome is membranous nephropathy. So it is
your syndromic diagnosis is nephrotic syndrome. You don't bother about what is the original diagnosis of the patient. So you think logically, 6th decade, nephrotic syndrome, elderly individual, what are the possibilities?
So possibilities including membranous nephropathy.
So the first possibility is
Membranous
membranous nephropathy. Apart from this,
then other causes, there can be FSGS, MCD.
Commonly then FSGS. What are the other pathologies you come across in a 65-year-old lady?
Nephrotic range proteinuria. There can be an MPGN, which can even present with the membranous nephrotic syndrome.
MPGN.
Amyloidosis is other possibilities to be considered. And then
paraproteinemia associated
glomerulonephropathy.
glomerulonephropathy presenting as nephrotic syndrome. Very well taken. Yes. Anything else?
Then minimal change disease still has to be considered.
Minimal change. Yes.
Okay.
And then idiopathic nodular glomerulosclerosis, fibrillary and immunotracted glomerulonephropathy.
Okay. Fine. And IRG IRGN also is increasingly reported
Yes, sir.
nowadays, but it
IRGN?
not runs this kind of a relapsing remitting course. In general, these are the pathologies. Okay, and again, the pathologies, glomerular pathologies, which you have mentioned, membranous nephropathy and minimal change. Always you have to think whether it is a
Secondary cause.
particularly secondary to
Secondary to malignancies
paraneoplastic. One more.
and infections or drug intake,
Membranous nephropathy in this part of the world, like in India,
drug induced secondary to allopathic medications or heavy
CAM.
metal poison,
complementary
alternative medicines.
alternative medicine associated membranous nephropathy. And of course, primary membranous nephropathy also can happen in this age group. Okay. Of all these, then, so where do you place FSGS here in this list?
So the primarily I made FSGS in the first list because of the treatment course patient has received.
So,
The treatment course is more likely a treatment for MCD bar FSGS
All the possibilities you can
That's very
also apply for
important,
minimal
actually.
change disease.
as minimal change disease also. Sir.
You haven't mentioned minimal change, only you have.
As a differential diagnosis, I have mentioned it actually.
Okay.
that's very important actually. Original diagnosis may be something. But
The
common
patient has
cause.
underwent a repeat
Approach
biopsy
is more
also,
important clinically.
so more favoring MCD bar FSGS for repeat biopsy.
How common is FSGS in this age group?
So FSGS predominantly occurs in a younger age group, less than 40 years. We can say it is the most common glomerular disease. So in the older, that is more than 40 years, FSGS is very unlikely.
What is the prevalence of FSGS among adult population?
So it is around, depends upon the locality. It is said that FSGS is more common in African population. It around 2 to 3 in 10 lakh populations in the US, whereas it reaches around 15-20 per 10 lakh population in the African population.
The literature says somewhere around FSGS 30 to 40% in adult population.
30 to 40% of total biopsies.
If you take nephrotic syndrome, 30 to 40% is contributed by FSGS
FSGS.
among adults. So what is the commonest cause of nephrotic syndrome among adults?
Among adults, in elderly population, most common is membranous nephropathy.
Membranous nephropathy. In which decades?
It's more common in 4th and 5th decade.
4th and 5th decade. Suppose if you consider this patient as a case of nephrotic syndrome due to membranous nephropathy, how will you proceed to confirm the diagnosis?
So we can do a renal biopsy to confirm the.
Momentarily, you just forgot about FSGS.
Okay, sir.
Just considering MGN as a first possibility, how will you proceed to confirm or exclude?
So we can go for a renal biopsy.
So
And-
straight away you will proceed with the renal biopsy when you suspect membranous nephropathy.
We can go for the primary membranous nephropathy markers like
So the
phospholipase
first
receptor.
step when you considering MGN, you have to rule out, confirm or rule out whether it is a primary or secondary.
Secondary. We can go for phospholipase receptor antibody testing. And if the titers are positive with a clinical presentation of nephrotic syndrome, we can straight away make a diagnosis of primary membranous nephropathy.
If MGN is the underlying cause in this patient, could it be a primary one or secondary one?
It can be both, sir. It can be primary or it can be still secondary. So if it is a PLA2R positive, more favoring a primary membranous nephropathy, as 80% of patients will have this PLA2R antibody positive. So secondary membranous nephropathy, since this patient have no other systemic symptoms, no other suggestive of any malignancies, no history of intake of any medications. So secondary MN is actually a diagnosis of exclusion. Since no features suggest a secondary, more favoring a primary membranous nephropathy has to be considered.
When you try to exclude secondary causes of membranous nephropathy, what are the investigations you will do?
So we have to screen for the malignancies, especially. That's most common solid organ malignancies has to be ruled out. So a general screening for malignancies for that age group should be done for this patient. For a male patient, PSA should be done.
So
Thyroid
age
screening.
appropriate screening test
Screening.
for malignancy. Okay.
Yes, sir. Then we can ask for the history of any medications history. We can ask for this patient and we can rule out that straight away.
What are the commonly prescribed medicines which are often ends up in membranous nephropathy?
So some heavy
Commonly prescribed medicines.
some Ayurvedic medications which contain heavy metals might have caused.
Heavy metals are not prescribed.
No, sir, but maybe skin whitening creams which contain mercury chloride
Contaminants,
or
contaminants.
That is one thing which have to be ruled out.
Any allopathic drugs which can cause membranous nephropathy?
As allopathic drugs, NSAIDs, which is mainly known to cause MCD, gold.
Okay, for that, apart from this malignancy and drugs, what other possibilities? What are the other causes?
Other
of
autoimmune
secondary?
disorders.
Okay.
Autoimmune disorders have to be ruled out, like SLE, rheumatoid arthritis, or chronic infections, non-healing ulcers, bronchitis, tuberculosis. Some things we have ruled out case of secondary MN.
Infections. So you will rule out all chronic infections like hepatitis B, and
Hepatitis B,
C, HIV,
and the inflammatory conditions also.
So what are the positive findings in the clinical examination?
Clinical examination, patient is moderately built and nourished. She's having no pallor, and no lymph node enlargement. Patient having bilateral pitting field edema for this patient. Actually, no other significant positive findings, sir, actually.
No, any features suggestive of the side effects of steroids in the general examination?
No, sir, examination wise, there was no significant side effects.
Nothing
For
else.
mild abdominal striae were present.
What are the blood pressure you said?
She was having 150/90 millimeter mercury.
150 over 90. Cardiovascular, respiratory system, everything is normal.
That's normal.
Right. So how will you proceed? How will you investigate? Suppose you were the nephrologist. You saw her 2 years ago when she presented to you with anasarca.
Yes, sir.
So the investigations, can you just run through the investigations?
So we have to do a routine examination for this patient, which include a urine routine examination to look for whether proteinuria is there, and similar routine investigation which include hemoglobin, ESR, and other routine investigations. Look for the serum albumin level and to confirm a diagnosis of nephrotic syndrome for this patient. So next one we have to look for the cause for this nephrotic syndrome. So we can rule out the common screening can be done for HIV, HBs, HCV can be done, and we can proceed with a renal biopsy as it is much cheaper and easily available investigation. So we can go for renal biopsy, and depending upon the morphological diagnosis in the renal biopsy, we can further plan the workup for this patient. If it is a membranous nephropathy,
I argue the other way around, like you said, biopsy is inexpensive, so you will straight away go for. I would say, like, I have a strong suspicion for this lady to have a primary membranous nephropathy. So I would run a serological test. If that is positive, I will not do biopsy. If I take a stand, what's your comment on my stand?
so
What that serological test is?
phospholipase A2 receptor antibody.
Okay.
So even KDO says that if patient with clinical compatibility with the PLA2 or antibody positive, we can straight away make a diagnosis of membranous nephropathy.
What is the prevalence of positivity of plateau R antibody in primary membranous nephropathy?
80% of patients will have positive PLA2
What
or
is the
antibody
specificity?
of PLA2R. This is actually more than 90% specific.
More than 95%. So please remember, these are the two words you have to use, not sensitivity. It
Okay,
is
sir.
the
Specific.
positive prevalence. It is not sensitivity, because this is not the only antigen, only antibody, because there are other antibodies as well for primary membranous. So you can't use the parameter metric as sensitivity. It's only prevalence rate and then specificity. Okay. So, but you would still like to do biopsy. If suppose if it comes as positive, straight away you'll go for therapy, or
Sorry, sir.
suppose the titer comes as positive, still you would like to do biopsy, or you will straight away proceed with treatment.
So still I would like to do biopsy for this patient.
Why?
To confirm the diagnosis, one thing, to make it 100% confirmation, to also know some
Prognostication.
prognostication
There are certain
effect.
parameters. You don't know how long it was there, particularly. If it's very significant, and suppose there is only partial response, you will not try too hard in a 65-year-old lady. So there are some subtle reasons. Of course, that by itself is a separate argument in such a situation. So that is number one. What other tests you will do?
For if we get a primary
You have to rule out paraproteinemia. That's what you said.
Paraproteinemia,
You
yes,
said
sir.
low back pain is not there. All that nice history you said. Okay. So what are the pathologies, glomerular pathologies associated with paraproteinemias which present as full-blown nephrotic syndrome?
membranous nephropathy, minimal change disease.
No.
Yes, sir.
Paraproteinemia associated glomerular, not paraneoplastic,
Okay.
like myeloma kind of thing.
Okay, there can be amyloidosis, fibrillary
AL
glomerulonephritis,
amyloidosis.
AL
Yeah, that
amyloidosis.
presents. Which other pathology in glomerular pathology presents as full-blown nephrotic syndrome?
There can be fibrillary glomerulonephritis and immunotacto,
Much more commonly.
paraproteinemia.
A light chain deposition disease.
Light chain deposition disease.
It's very common. There are certain other pathologies as well. Heavy chain, light and heavy chain, PGNMID. Right? There are a big list of glomerular pathologies. Okay. Then you said about minimal change. Okay. Is it always primary minimal change or secondary causes you would like to rule out?
Yes, sir. Secondary causes also have to thought about.
Which are the common secondary causes for minimal change that can present as nephrotic syndrome in 65-year-old lady?
Malignancies like Hodgkin
Which
lymphoma.
malignancy?
Hodgkin lymphoma, non-Hodgkin lymphomas.
And drug?
Uh,
Which drug can cause MCD, very commonly consumed in
NSAIDs can cause.
which NSAID particularly? Ibuprofen.
Ibuprofen.
Okay, fine. Then membran nephropathy. Which are the common malignancies that are associated with membran nephropathy as paraneoplastic in a 65-year-old lady?
Colorectal carcinoma, solid carcinoma mainly, colorectal carcinomas, lung carcinomas.
CA stomach, colorectal carcinoma. Okay, fine.
Yes, sir.
So this is how you have to approach. So we haven't discussed FSGS at all, right? It comes much down in the list. So that's very important.
Okay, here the biopsy of this patient has been reported as FSGS.
How common is IRGN in the elderly?
So nowadays IRGN is becoming much more common in elderly population.
Are you aware of any publication from India as quoting the high prevalence of incidence of IRGN in the elderly?
So MMC has published, I think so.
MMG is part of the publication. Actually, it is from nephropathologist Dr. Anila. IRGN is common, very common. Okay. Can ANCA disease present like this?
Sorry, sir.
ANCA disease.
With nephrotic syndrome.
ANCA disease also is another pathology in this age group, but the clinical syndrome is a bit different. It will not present as a kind of a full-blown nephrotic syndrome at all. Please remember ANCA also in this book.
Okay, you can now read the slide.
Okay, sir. Light microscopy picture of renal biopsy with the past staining is showing a segmental sclerosis in the glomeruli visualized with the normal capillary lumen, and no capillary wall thickening can be seen, and no proliferation of visceral epithelial cells. And it's because I cannot identify the tubules or the vessel here, so I cannot definitely tell the variant.
Just look
And
at
no
the-
cellularity, no increase in mesangial cellularity seen, so we can rule out the cellular variant of FSGS.
How about the capillary loops?
Capillary loop seems normal only, sir.
What could be there, this type? You mean cellular variant?
No, sir, cellular variant is unlikely because there is no mesangial hypercellularity is not, sorry, endocapillary hypercellularity is not seen.
So
So-
what is this type?
So it might be
Can
not
you
otherwise.
come to a conclusion based on this, on your findings? Can you categorize
So,
belongs to which variant of
Sir,
FSGS?
so three variant can be considered not otherwise specified or perihilar or tip variant, but here the proximal tubules are not visualized as well as the arterial pole is also not visualized. So not otherwise specified.
You apply the features of collapsing, cellular,
It is not
perihilar.
It is not collapsing variant. It is
Okay.
not cellular
So
variant.
it doesn't appear, looks like collapsing.
It doesn't look like
Okay.
collapsing.
Then
And it is also not a cellular variant.
cellular variant.
Not
doesn't
cellular
appear.
variant, yes.
Okay.
So it could be either a perihilar variant or a tip variant.
What is perihilar? What is the definition of perihilar?
Perihilar means the sclerosis is seen around the vascular pole, which is seen around more than 50% of glomeruli.
So the hyalinosis and sclerosis is mainly confined to the
Vascular pole.
vascular pole. So in that case here, where is the predominantly the sclerosis and where is it located?
It is more center portion. Central, the below bottom half of the glomeruli in the picture.
It is close to the tubular segment. So it doesn't belong to perihilar variant. There is no evidence which is supportive of collapsing, cellular and perihilar. So what is most likely it could be?
It's not otherwise specified variant.
NOS.
NOS.
Not otherwise. It's a diagnosis of exclusion. So before you make the diagnosis of NOS, you have to exclude all other features. Okay. Tell me, how will you plan your management? Adult FSGS.
Okay, sir.
What is your goal in
Goal
treating?
is in treating is attain complete remission for the patient. That is
So you always try to achieve
achieve
complete
remission.
Okay.
So for
What percentage of FSGS patients, adults, they achieve remission, complete remission?
so complete remission can be achieved with multiple treatments. It can be reached around 60 to 70% of patients can be complete remission can be attained.
With initial
Initial steroids alone,
high dose steroids, how many percentage of primary FSGS individuals
around 50 to 60%.
complete remission? What you are telling is
sir.
cumulative.
Sorry,
Both
20 so,
complete
around-
and partial
around 20%,
remission is
20.
around 50 to 60%. Okay. So before you initiate them on high dose glucocorticoids, what you have to ensure before always in primary FSGS in FSGS patients?
So FSGS, we have to rule out secondary FSGS for these patients. So we have to make sure it is primary FSGS alone.
Okay.
So for that, the patients usually present nephrotic range proteinuria. They will be having a nephrotic syndrome. Electron microscopy will be showing diffuse food process effacement. If no other causes of suggestive secondary FSGS, we
Yes.
can make a diagnosis of primary FSGS because immunosuppressives are given only for this primary FSGS patients.
So in all FSGS patients, adult patients or whether adults or children, two things you have to remember. One, confirm whether it is a primary or secondary. That is the first step. Second, immunosuppressive treatment is indicated only when they have
Nephrotic range
nephrotic-
proteinuria, nephrotic syndrome and nephrotic range proteinuria.
So how will you differentiate between primary and secondary FSGS?
So clinically.
Clinically as well as histopathologically.
So clinically, the secondary FSGS patients usually won't present with much edema or nephrotic syndrome presentation is usually unlikely for this secondary FSGS patients. And they will be having, they may have some nephrotic range proteinuria, edema or hypoalbuminemia is little bit unlikely. And they usually have a slowly progressive course of illness. Whereas this primary FSGS, they have an abrupt onset of pale edema or abrupt onset of symptom initiation. That's how we can clinically manifest these patients. And other clue is that they doesn't respond to steroids, immunosuppressions. That's another clue for when we think of secondary FSGS. That's how we can clinically. And histopathologically, the perihilar variant is more common in secondary FSGS along with the glomerulomegaly or the glomerulomegaly and the mesangial hypercellularity or other features.
Based on glomerulomegaly,
We cannot differentiate much. There is presence of other features like presence of mesangial
what
hypercellularity
is
or
the one important histopathological finding which will definitely differentiate between primary and secondary?
so diffuse food process effacement is more favoring a primary FSGS, whereas less than 50% food process effacement is more favoring a secondary FSGS.
Very good. So clinically, primary FSGS almost always, how many percentage of primary FSGS individuals will be having nephrotic range of proteinuria?
That will be 100.
Nephrotic syndrome. How many percentage of primary FSGS individuals will present with nephrotic syndrome?
I think it's 100% or more than 90% likely.
Around 55 to 60% of individuals present with the nephrotic range. Most, the remaining 40%, they may have non-nephrotic range of proteinuria. How common is renal failure during the initial presentation of FSGS?
So renal failure can be seen around 10 to 20% of patients at the time of presentation.
1/4 of individuals, primary FSGS individuals, they can have renal failure at the time of presentations. What about hypertension in FSGS?
Hypertension, 50 to 60% will have hypertension.
52. Why do they develop hypertension?
Because of the
What
focal,
is the pathomechanism of hypertension in FSGS?
so because of the focal scarring occurring in the kidney, which will result in RAS activation, sympathetic nervous system activation.
Someone who doesn't have much scarring or sclerosis,
Activation of the INAC channels resulting in more sodium and water retention, resulting in hypertension.
that is the dominant mechanism of hypertension in primary FSGS. Okay, now you have ensured that the given patient is primary and patient is having nephrotic syndrome. Then how will you proceed to treat?
So we have to start the patients on maximum tolerated dose of ACE inhibitors and ARBs for this patient. And since the primary FSGS, we have diagnosed primary FSGS, we have to treat with immunosuppressants. So we have to look whether the patient is responsive to steroids or not. So we can start him on 1 mg per kg of dose of steroids for the patient, and we can look for the response for the patient. So if the patient doesn't attain a remission by the week of 16 weeks, we can label this patient as a steroid-resistant nephrotic syndrome. So in case of steroid-resistant nephrotic syndrome, the second best choice is calcineurin inhibitors.
That will go later. What is the definition of complete remission in FSGS?
So complete remission is defined as urine PCR of less than 0.3 milligram per gram, or the 24-hour urine protein excretion of less than 300 milligram per day, with serum albumin of more than 3.3. It's defined as complete remission.
Some of the patients, they are unsuitable to initiate them on high-dose steroids.
Yes, sir.
In those patients, what are your alternate options as a first choice?
Yes,
Who are all the patients
So,
where
some patients
of high-dose steroids may not be possible, or the nephrologist may not initiate with the steroids?
The patients with uncontrolled diabetes, or with psychosis, or having some recent osteoporosis, so, or with the patients, the non-glucocorticoid toxic patients, these patients are not suitable for high-dose glucocorticoids. So those group of patients, we can go for the second-line agents. That's mainly the CNIs is mainly described in FSGS. So in case of MCD, they have much more options for us, like MMF, rituximab, or cyclophosphamide. For FSGS, KDIGO doesn't say much about other things.
So apart from CNIs, what are the other options?
So the options we are having is including MMF or rituximab, cyclophosphamide. These are some other options which we have.
Out of these cyclophosphamide, MMF and CNI, which one you would prefer as a first choice, as an alternate to steroids?
So first choice I will choose CNI only,
CNI.
Oh.
Why?
because it is the recommended for steroid-resistant nephrotic syndrome or FSGS. We are going with CNIs, which is known to cause decreasing proteinuria.
What are the advantages of initiating these patients on CNI, and what are the limitations of CNI in nephrotic syndrome?
So CNIs has some direct action on the podocytes, which can reduces the proteinuria in these patients. That's the main advantage, and the morbidity mortality depends upon the proteinuria. And the main disadvantage is that the toxicity effect of CNIs, especially the chronic tubular interstitial effect caused by the CNI, and high rate of relapse after stopping the CNIs. That is the main disadvantage of CNI.
So what is the reported rate of remission rate with the CNI?
With FSGS, sir.
FSGS. We are talking about FSGS.
FSGS remission rate around 60 to 70% remission rate with the FSGS, remission with the CNI.
How much?
60 to 70, sir.
60 to 75% of individuals achieving both complete and partial remissions.
So having known the diagnosis, histopathology, any specific history you would like to elicit to ascertain the cause for FSGS in error, particularly with relevance to the drug intake?
Secondary.
The
Drug
drugs
in-
causing FSGS?
Maybe anabolic steroids.
Anabolic steroids. Is it sometimes, it's a common practice among the general practitioners to administer an anabolic steroid for elderly people who complain of fatigue and so on. Something else? Any treatment for osteoporosis?
The pamidronate, interferon therapies, which can cause collapsing
As you
FSGS.
rightly said, these secondary forms of FSGS will not present with full-blown nephrotic syndrome. There may be nephrotic proteinuria, but classical phenomena of nephrotic syndrome. But still, these are the ways to. What do you mean by sclerosis?
Sclerosis means the expansion
Is
of
there
the
any difference between fibrosis and sclerosis? Or they can be changed, it can be interchanged.
So the sclerosis, the main compound is actually the collagen only, where there is increase in mesangial expansion and this obliteration of this capillary lumen. We can say it as sclerosis.
You mentioned about the 5 variants. What is that classification actually?
Columbia classification, sir.
What is your personal impression about this Columbia classification? Do you think this Columbia classification will be in vogue the coming decade also, or it will just go off?
So it has some role in prognostication. As we know, the collapsing variant
That's
has.
what. Initially, we thought that it's going to be of great help in terms of understanding the pathophysiology as well as prognostication. For instance, we believe that a tip lesion has got very
good
favorable
prognosis.
All that has been proved to be wrong now. There are any number of reports coming up negating that idea, right? So I think it's only a matter of time. And again, collapsing variant, it is totally entirely different ball game. That cannot be classified under
FSGS.
Okay, collapsing is entirely different pathomechanism and it has got different prognosis and so on. So you will come across a different kind of classification shortly. Like, I mean, it will not be this thing. Okay, fine. You said cyclosporine you would prefer. And you said how does it act?
So cyclosporine, there is a calcineurin dependent phosphorylation of this.
In this situation, you said directly acts on the podocyte, you said.
So that's what I'm saying. There is a calcineurin dependent phosphorylation of synaptopyrin occurs, which can disrupt the actin cytoskeleton in the podocytes.
So you mean to say the benefit of cyclosporine, if at all, it is more mechanical rather than immunological? That's what you mean to say?
It has a mechanical, additional effect of mechanical also.
Okay. If it is purely mechanical, as long as the drug is in the system, it will act, right?
Yes, sir.
The moment it is off, again?
It will relapse.
Oh.
That's what we're seeing with CNAs.
That's what we believe, right? And you said the primary FSG is abrupt onset. What does it indicate? Why is it so abrupt?
So primary FSGS, the pathogenesis they are saying is the presence of some circulating factor which damages this podocyte, resulting in this thing. So this.
Which are the putative, the permeability factors?
Like soluble urokinase plasminogen activated receptor, SUPAR, or cardiotropin like cytokine factor, or anti-CD40 antibodies, or ApoA1B.
Fine, all that is okay. How come these factors were not come into picture until 65 years of age?
So that's they're saying that there may be some extra trigger, environmental trigger that may have occurred in that patient who is predisposed for this syndrome.
And in the clinical examination, did you mention the BMI of that person?
So BMI actually have looked, but since this patient is edematous, the BMI will not be much useful.
What is the significance of BMI in this pathology?
In this pathology, sir, in obesity-related glomerular sclerosis, there is an NDT.
What is ORG, obesity-related glomerular?
So there is one example of a secondary FSGS, which is thought to be caused because of the glomerular overload occurring in this patient. There's one mechanism they are describing. Another mechanism because of the inflammatory milieu seen in obese patients, resulting in more oxidative stress and more inflammatory damage resulting in FSGS.
It mimics FSGS, it is a unique entity. There are certain differences. Please read up about that. Okay.
Generally, whenever you come across FSGS individuals, whether especially pediatric FSGS, when will you consider genetic mutations as an underlying possibility?
So genetic testing should be done for all steroid-resistant nephrotic syndrome, in congenital infantile nephrotic syndrome, or patient with syndromic features or a family history of nephrotic syndrome. You have to go for genetic testing.
What is the natural history of FSGS? Primary FSGS.
So natural history around spontaneous remission they are saying is around 20%, around 15-20% in 1 year. And if we have not treated these patients, around 50% will go for ESKD by 8 to 10 years. That's the natural progression.
Suppose if the patient has reached ESRD, how will you prepare this patient for renal transplant?
So the additional thing we have to consider regarding if we know the native etiology of kidney is primary FSGS, we have to thought about the recurrence risk of this patient in our case. And
what will be the recurrence rate with
in primary FSGS, recurrence rate is around 30% of recurrence in transplant kidney.
graft loss?
And if the patient had a recurrence, the graft loss will be around 50% graft loss within 5 years.
How soon FSGS recurrence can happen post
So
transplant?
there can be a very early recurrence, that is within the first 2 days there can be recurrence. Median period is around 1.5 months is the median time period for recurrence. But there is an early, intermediate, late recurrence where the early is within 48 hours, intermediate is 2 days to 3 months, and late is after 3 months of recurrence.
So even it can recur immediately after releasing the clamps. That is
Yes,
the
sir.
one which is mainly supporting your permeability factor hypothesis. Okay. So how will you monitor those individuals, those who had FSGS as a basic native kidney disease, when you subjected them for renal transplant? How will you monitor?
So post-transfer, you have to monitor proteinuria for these patients. So we have to monitor daily proteinuria for the first 1 week, and then twice weekly for the second week, then weekly for up to 1 month, and then monthly for the 1 year, and then 3 monthly for the follow-up period. We have to monitor proteinuria.
How will you manage post-transplant recurrence?
So the patient will be already on the immunosuppressants, which usually have steroids, cyclosporin or MMF, and we can give the plasmapheresis for these patients, which has a good response in post-transplant recurrence. So we can give a daily plasmapheresis of 3 sections and followed by alternate day plasmapheresis, and till the patient's proteinuria decreases to less than 1 gram per day.
So how long you will continue plasmapheresis until you achieve less than 1 gram?
So usually we are expecting,
What is the literature says? How long you can continue?
maybe up to 2 weeks.
Is there any consensus on post-transplant FSGS recurrence treatment with the plasmapheresis?
Yes, sir. Initially we have to give continuous 3-day sessions followed by alternate day. Maybe up to 2 weeks maximum we can continue plasmapheresis.
There is no consensus is available. As long as is needed, we can continue.
As long as needed.
So what is the supportive therapy for her? You discussed elaborately about the specific therapy. Supportive therapy. For
Supportive
the
therapy we can give
Just
RAS.
the principles, just quote.
So we can supportive therapy we can give RAS inhibitors because it is known to reduce the glomerular hypertension.
RAS inhibition.
Okay.
Edema, for edema what do you do?
For the supportive treatment, sir. So edema we can give diuretics can be given for this patient along with maybe albumin supplementation might have been received
So
for
what are
this.
the challenges in diuretic therapy in nephrotic state?
So nephrotic syndrome, the diuretic state is diuretic resistance, which occurs because of mainly 2 reasons.
Why?
One, because of the diuretics which reaches this kidney is actually protein bound. Since the hyperalbumination, the protein.
Furosemide, right?
Yes, sir, furosemide, talking furosemide, sir. The protein bound furosemide is actually less, so only less furosemide reaches the basolateral surface.
Is more. Yeah, it is not confined to the vascular compartment.
It is not confined to vascular compartment, and only the protein bound reaches the basolateral aspect, so only less amount of protein can be secreted into the lumen itself.
Okay.
And also there is some proteins in the lumen which will bind to this furosemide, hence lesser furosemide is available for acting at the
So what are the complications
receptors.
of escalating the doses of furosemide in a nephrotic state? What are you concerned about?
So our concern is regarding the volume depletion occurring in this patient. So volume depletion can predispose for this patient for AK as our one concern for this patient.
Usually
And then
right.
interstitial nephritis can be caused by this
So what's your
furosemide.
take on statins?
Sorry, sir?
Statins in nephrotic syndrome?
So statins can be given in nephrotic syndrome for 2 reasons. One, this nephrotic syndrome patients will be having hyperlipidemia. So statins can be given for, especially for this patient who is expected to have a long period of maintaining nephrotic state. And one other is that statins are said to have some beneficial effect in reducing proteinuria by its action on these podocytes.
Fine. You said steroid and then CNI and then you said you'll try other measures. Suppose imagine a situation she does not respond to any of these therapies. What are the newer avenues?
Means no response to
Have you gone
steroids,
through the,
CNI, MMF.
NEJM publication of Duplex trial?
Sorry, sir?
Duplex study? Duplex?
Plex trial. Not sure, sir.
Yeah.
Sparsentan. Okay,
What is
sir.
Sparsentan?
Sparsentan is endothelin
Please
receptor.
go through that. Any nephrology article published in NEJM assumes greater significance. It is
Anti-endothelin.
plus.
It's dual actually, sir. Endothelin plus angiotensin receptor
It
anti.
is a
receptor.
positive trial or negative trial?
Duplex trial might be positive.
It's a negative. Actually,
Negative.
it has brought down the proteinuria, but it was not translated in improving the renal survival. So approval has not been given. And you said CD40. No, what are the permeability factors? Any monoclonal antibody for that? You know.
CD40 monoclonal antibody, sir. Not sure.
Fine.
What is diuretic resistance? When will you say a given patient, edematous patient, is resistant to diuretics?
So, when the patient is not getting an adequate diuresis for the normal dose of
What do you mean
diuresis.
by adequate diuresis for you and for us? It's not the same for everyone.
A dose of around 1 mg per kg of furosemide given to patient. We are expecting.
No.
Uh,
Any postgraduates from the audience? Anybody knows the definition of diuretic resistance? When will you label a patient as a case of diuretic resistance? Yeah. No, it is not based on sodium level, because sodium level varies with individual to individual hydration status and intake based on sodium intake of that particular individual. So it's actually there is no proper definition is available for diuretic resistance, but universally accepted definition is if with appropriate and adequate diuretics, if any patient is unable to achieve more than 2 kg weight loss in a day, then we can consider that as diuretic resistance. So actually the goal when you are treating a edematous patient with nephrotic syndrome, try to achieve minimum 2 kg weight loss in a day, but never try to exceed more than 2 kg weight loss in a day. So that is the thing. Okay, when will you escalate the existing diuretic dose or add a newer group of diuretics while treating edematous? Because these are the problem we commonly come across in our clinical practice. Some of the patients, they may not respond to your loop diuretics. So when will you consider to add newer group?
So if the patient is having attained adequate diuresis with the loop diuretics, then we can go for the other agents which act more distally, like the thiazide diuretics or this amiloride, or we can add actually.
What are the other complications of nephrotic state, particularly a person with anasarca? Apart from the renal prognosis, we are worried about certain other things, like
So the complication
so
major
your management always, I mean, normally we get focused more on the specific therapy, but the supportive therapy and envisioning the potential complications and addressing them assumes greater significance. That's why I'm asking all these questions.
So the main complications are hypoalbuminemia itself, which can result in edema, platelet hyperaggregability.
So will there be vulnerability for infections?
Yes, sir.
So what do you do that for that?
Sorry, sir.
So what do you do for that?
So infections occurs in these patients because of few factors. One is because of loss of immunoglobulins, loss of complement factors through the urine. Also, these patients are more predisposed because of the edema, which can act as site for infections, or the skin abrasions, which may act as a site for development of infections for these patients. So for this patient, so as recommendation, every patient who are receiving more than 20 mg of steroids or other immunosuppressants, we should give prophylactic antibiotics. So for cotrimoxazole can be given for this patient, especially when the patient is on high dose steroids regimen.
What is the role of anticoagulation?
Sir. Next is the other complication is the hypercoagulability in these patients. So the recommendation for anticoagulation depends upon mainly two factors. One is the level of serum albumin, another one is the risk of bleeding in these patients. So for the patient, the serum albumin of less than 2, if the patient is having a low risk of bleeding, we can go for anticoagulation. And if the patient is high risk of bleeding, we can go with antiplatelet agents. If the serum albumin is more than 3, then depending upon whether the patient is a high risk of arterial thrombosis, we can go for this antiplatelets. And if it is low risk, means we cannot be no need of any anticoagulants for this patient.
So you know the current classification of FSGS as per 2021 KDIGO, because it keeps changing.
Yes, sir.
When I was a student in 1990s, we used to have primary and then secondary. Then
Now
it
it
became
is
primary, adaptive and secondary. Now what is the current
Now it is a
classification
primary,
as per KDIGO?
primary, secondary, genetic, and FSGS unspecified, unclassified.
Unknown cause, UC.
Unknown cause,
FSGS, UC.
UC.
So what is the clinical presentation of FSGS UC?
So those group of patients are actually having a nephrotic range proteinuria, but without hypoalbuminemia, or this nephrotic range proteinuria without the nephrotic syndrome as such.
So when you come across FSGS UC, how do you treat?
So for those patients, we have to definitely look for, they are more likely a secondary FSGS with unknown secondary cause.
So you should not start straight away
immunosuppressants.
steroids.
We have to look for the cause of this.
Follow up and try to find out the cause and then try to understand the natural history. If the situation worsens,
Worsening, then we can go for immunosuppressants.
So that's it. What is the animal model for FSGS?
So there are different animal models.
I can't
Mr.
resist asking this question, even though it is a bit irrelevant for the current scenario, because I always encourage all of you to learn animal model, because without those great work of the yesteryear scientists, science would not have evolved. Now currently all those animal models don't have any kind of major relevance, but still we have to respect how understanding progressed and evolved over a period of time. Always history of any disease is important. At least for that sake, please remember. If not elaborately, at least one liner.
Mr. Venich rat model 5/6
Yeah,
nephrectomy.
there are multiple animal models based
sir.
on each pathophysiology.
There is 5/6 nephrectomy model
Or
or
primary, I'm asking about primary.
How do they
primary
induce
FSGS cells.
Primary.
How do they induce FSGS?
They are giving toxin like puromycin aminonucleoside, given
What
adriamycin
is the
toxins.
animal model for MCD?
MCD is a rat models are mainly.
The same puromycin aminocyte.
Pure aminonucleoside.
But the dose that is administered for MCD is
Lesser dose. Thank you.
Very good. It was a pleasure examining you. I would say it was a real pleasure examining you. Only negative. In Tamil we call it as drishti puttu, like it's a kind of what is that? Straight away you jumped and said FSGS. Never do that. That man, in fact, better not to know the diagnosis whenever you approach the hall. Even if somebody wants to tell you the diagnosis, you just say that don't tell anything. Because the actual diagnosis can be entirely different, but how we approach is more important. That is only one negative. Otherwise, you are very well done. I thoroughly enjoyed it.
Thank you, sir.
Thank you very much, Dr. Prasoon.